You know, we prescribe a whole lot of chemotherapy, but most of us have never taken it or taken it home with us, for example. And so we have this sort of idealized vision of what it's like. And we mostly see that patient like 2 weeks later after they've recovered. So we're not seeing them at their worst, typically. I think that's a great oncologic trick. So as best we can do, we need to describe to patients how they're going to feel. For me, the Gem/Abraxane is really a pretty easy regimen to describe how one feels because it's quite predictable in terms of the acute side effects are very manageable, the nausea is minimal. Most people, I say, can drive themselves back and forth to get the treatment. I talk about cumulative side effects and the need for blood counts. And then I talk about the different regimens, different recipes, the 3 weeks on, 1 week off, the every other week, the 2 week on, 1 week off, because patients are setting in their calendars these regimens. And a lot of times we look up, okay, it's 3 weeks on, 1 week off. Well, if everything in that patient's life is set for that, and then on week 3 they can't get the treatment because their counts are too low, their whole world is now in turmoil. So giving them a sense that this is flexible and we change on the fly, I think is really important for that regimen. I also emphasize that we're going to do this for a couple of months. We're going to follow your marker, we're going to follow you, and we're going to then do repeat scans and see if it's working or not. And depending on how you're doing and how the scans are doing, we'll make a decision about going forward beyond that. The FOLFIRINOX is a little bit more time-consuming and challenging to describe because you have the mechanics of the treatment itself. So half a day or more in the infusion chair, getting the ox and the ARI, the pre-meds that are required, taking home an infusion pump for 46 hours, the post-meds that are really required to keep people's nausea down, and then the fatigue that comes, what I call the disconnect day, so that second day, third day of treatment. Patients, I tell them the couch looks really good, feels really good. You can get around, but you don't really want to. Eating is kind of off. Not so much you're throwing up, but you just don't want to eat for a few days. And then you start to feel better. A week later is when the diarrhea hits. Everybody's thinking diarrhea, but you actually are constipated for the first 3 or 4 days because of the anti-nausea meds. Then diarrhea a week later if you're going to get it. And then you worry about low blood counts too. It's one of the few regimens as a GI oncologist that I routinely give growth factor. So for most patients, that means bringing them back for day 3 to have the growth factor administered. Different docs and different offices manage that in different ways, but we routinely add growth factor in. We too plan for about 4 rounds of that. So we see them every 2 weeks. We check their labs, we adjust accordingly to how much their side effects were, we adjust the doses, and then again watch markers, watch patients, watch scans, and depending on how they're doing, set off for more treatment with that. Very hard to give much more than about 8 rounds of FOLFIRINOX total, and I tell that to patients up front. We have some specific goals we're setting. We want to get the cancer back, we want to drive it back. With Gem/Abraxane, it's much more of an open-ended, if this is going well, we'll just keep it going. With FOLFIRINOX, to me, it's sort of limit setting. I got about 8 cycles I can give. We have to remember the initial clinical trials were different. So the FOLFIRINOX clinical trial done in academic centers, PS 0 and 1, and had an age cap. So not that these people were marathon runners, but they were the best of the best, and they were managed in academic centers where they have disease-specific teams. The Gem/Nab-Paclitaxel clinical trial was a community-based study. You could have a performance status all the way down to 2, and there were plenty of patients over the age of 70 in that clinical trial. And I always think of that as more real-world pancreas cancer. And we know that pancreas cancer is different in my center than in our community centers. For example, the patients who can make it to me typically have a better PS, typically are younger, all that sort of thing. Whereas the patients who make it to community docs are a little older, have more comorbidity. So anyway, the Gem/Nab-Paclitaxel trial is more real world in that. And when they look at those various groups, if you pull out the sort of high performance status patients from the gem/nab-paclitaxel and the FOLFIRINOX clinical trial, those two groups perform very similarly. When you look at the overall clinical trial, there's some debate about whether the gem/nab-paclitaxel is weighted differently because of the lower performance status in the higher age group. So I believe that. I believe that in clinic and in practice. And so that's why I say I don't think there's a lot of difference patient for patient between the two regimens.